this rhythm, and he's addressed for severe mitral valve regurgitation due to bilateral valve. Ejection fraction is good, left atrial dimension is 48, and this is the echo. And you see that there is the curling motion of the posterior aspect of the ventricle. You see that the posterior leaflet is not inserting normally, so it's a typical case for mitral annulus disjunction. And you have a prolapse of both leaflet. Whereas you can see that the jet is not central. The jet is anteriorly directed, which means that there is, you see the jet, which is that there is a prolapse of the posterior leaflet. It's more acute, so I would recommend you to do what Alain told us, to use just a ring in this case. So you see there is definitely a prolapse of both leaflets. The free edge of both leaflets are overriding the plane of the annulus. So we are going to operate this patient minimally invasively using 3D, as you can see. And so we do first the valve analysis. We have the reference point, and we check the anterior leaflet against the reference point, and we can see that we have no prolapse of the anterior leaflet. So despite the fact that on echo you have a prolapse of the anterior leaflet, you don't find this aspect on the surgical valve analysis. So we are not going to do anything on the anterior leaflet. For the posterior leaflet, you can see that clearly here you have a prolapse of the posterior leaflet. You can see also that at the base of the posterior leaflet, at the level of the annulus, there are some lesions that are not normal. If you place the posterior leaflet in the left ventricle, you see that it lies down nicely. So we are going to respect the posterior leaflet. And the first thing that we are going to do is we are going to close the indentation, P1, P2. The only thing that it can do is create problem after surgery. So we don't want problem, so we like to prevent that. So we'll close it. Those indentations are very useful in a normal mitral valve because during diastole, the annulus dilate and the posterior leaflet has to follow the motion of the annulus, and for this it needs to have some opening. It needs to have those indentations. But for after repair, we place a ring, we fix the valve in the systolic position, so those indentations are useless. The only thing that they can do is that they can show a regurgitation afterwards. So I did this with a locked running suture, which I don't do today anymore. I just use simple suture. As you can see, I used the wall of the left atrium as an assistant to expose things. And so you see that the posterior leaflet is mucoid degeneration. It's thick, it's high. So we are going to do respect, so we're going to use Gore-Tex, but due to the height of the posterior leaflet, we may be afraid of SAM if we would place the Gore-Tex at the level of the free edge. So we are going to use this technique that we have done in Bad Neustadt for quite a while. So we take the Gore-Tex and we go through the free edge, and then with several steps we bring the Gore-Tex behind the annulus. This has the effect of verticalizing the posterior leaflet. And if the posterior leaflet is irregular with some bulging and things like we can see when the mucoid degeneration is a little bit foolish, then it flattens the posterior leaflet. It makes it more smooth and regular. So here we are at the level of the annulus, a little bit behind the annulus. take superficial bites here because you don't want to hit the circumflex artery. So you do the same thing with the second arm of this first suture. Then we place another Gore-Tex at the level of the posterior papillary muscle. This is the posterior head of the posterior papillary muscle. So I was using figure of 8 suture at the level of the papillary muscle, and now changed with a mitral suture with a pledget. And so again, we place it at the level of P2. So the goal is to have the posterior leaflet in one thing, put down in the inflow. And so this is we go again behind the annulus with the first arm. We do the same thing for the second arm. And then at this point we do a water test just to see how does it look. So it looks nice. You see that the line of closure is really posterior. And so we can tie the knots. So we do a lot of knots. And those two guys which are staying there with their horn, they look like snails. So this is why we call this the snail technique. We remain a little bit childish in Baden-Neustadt. So then we measure the annulus, place the ring, and we have a good result. And if we do the echo, we'll see that the posterior leaflet is vertical, is well in the inflow, there is no risk of sand, we have no regurgitation, we have a high high surface of coaptation, so good result, no auditory. So if we do an analysis of this case, so we have this typical image of annulus disjunction. We have the prolapse here, disjunction, which was described, as I said, by Hutchins in 86. This is a very beautiful image of mitral annulus disjunction, how it looks on histology. And this is what it is. You know, you have the whole subvalvular apparatus which is attracted in the atrium. So this is why you don't have a real prolapse, at least of the anterior leaflet. So the aortic cross time was 66 minutes. The patient was without support, discharged from the ICU quickly, discharged from the clinic without any problem, with no regurg at pre-discharge echocardiography. So mitral valve disjunction is a real entity responsible for functional bileaflet prolapse. It can be recognized easily on echo due to the insertion of the posterior leaflet in the atrium and due to the curling motion of the base the Snail technique is a very versatile technique which verticalizes the posterior leaflet, which is maintained in the inflow away from the outflow. It's the best anti-SAM weapon that I know. It flattens the posterior leaflet when it is irregular, and I would say that probably the only case where you have to avoid it is when you have no excess of tissue in height for the posterior leaflet. Thank you very much for your attention.
Thank you very much for the excellent presentation.